Good afternoon. Thank you for joining me today. My name is Dr. Aurangzeb, and I am a consultant cardiologist working at Sedu Teaching Hospital in Swat. Today, I will be presenting the new American College of Cardiology 2024 guidelines on peripheral arterial disease, highlighting what's new and important for our clinical practice. So let's begin our lecture. This is the outline of our presentation. We will go through what has been changed, specifically what additional information on health disparities, classification of peripheral arterial disease, significance of peripheral arterial disease, diagnostic tests, risk amplifiers, medications, revascularization, exercise, and follow-up. Just let's have a quick recap of what exactly peripheral arterial disease is. And it's a common circulatory problem where narrowed arteries reduce blood flow to the limbs. It affects millions worldwide, causing significant morbidity and mortality. Understanding and adhering to updated guidelines is crucial for improving patient outcomes. A new section named Addition of Information on Health Disparities. The 2024 Peripheral Arterial Disease Guidelines recognizes the intricate relationship between peripheral arterial disease and health disparities. In the previous guidelines, health disparities and their impact on diagnosis, treatment, and patient outcome were not examined. Peripheral arterial disease can be classified based on the clinical presentation of the patient with objectively confirmed peripheral arterial disease into four clinical subsets, and these are asymptomatic peripheral arterial disease, chronic symptomatic peripheral arterial disease, chronic limb-threatening ischemia, and acute limb ischemia. Patients with asymptomatic peripheral arterial disease represents 20 to 59% of all patients with objectively proven peripheral arterial disease. A significant proportion of patients who report no exertional leg symptoms will develop symptoms during an objective walking test. This emphasizes the importance of diagnostic tests because most of the patients with peripheral arterial disease are asymptomatic, and these patients have an associated increased risk of major adverse cardiovascular events, including mortality. First, let's talk about the diagnostic tests, and the easily available test is the ankle brachial index. The guidelines now states that in patients with a history of physical examination findings suggestive of peripheral arterial disease, a resting ankle brachial index is recommended to establish the diagnosis of peripheral arterial disease, and this is a class 1 recommendation. And in patients at increased risk of peripheral arterial disease, they can be screened for peripheral arterial disease with a resting ABI. This is a reasonable approach, and this is a class 2A recommendation. So for patients who have clinical symptoms suggestive of peripheral arterial disease, this is a class 1 recommendation. And for high-risk patients who are deemed to be at increased risk for the development of peripheral arterial disease, ankle brachial index can be used for screening as well. For patients with chronic limb-threatening ischemia, it is reasonable to use toe pressure or the toe brachial index with waveforms, transcutaneous oxygen pressure, and/or skin perfusion pressure in addition to ABI to establish the diagnosis of chronic limb-threatening ischemia. So these are the second-line tests after you have performed the ankle brachial index. Either toe pressure, toe brachial index with waveforms, transcutaneous oxygen pressure, or skin perfusion pressure. These are the additional diagnostic tests. The section on risk amplifiers for peripheral arterial disease. When evaluating a patient with peripheral arterial disease, clinicians should assess for and incorporate the presence of PAD risk amplifiers when developing patient-focused treatment recommendation. Always look for PAD risk amplifiers. Every patient should be assessed individually, and the risk amplifiers include race and ethnicity, geography, structural racism and implicit bias, social determinants of health, age, diabetes, tobacco use, chronic kidney disease, polyvascular disease, microvascular disease, and depression. The section on antithrombotic medication, this is very important, and in patients with symptomatic peripheral arterial disease, single antiplatelet therapy is recommended to reduce the risk of major adverse cardiovascular event. This is a class 1 recommendation. This can be done with aspirin or clopidogrel. In patients with asymptomatic peripheral arterial disease and in patients who have undergoing endovascular or surgical revascularization, low-dose rivaroxaban 2.5 mg BD combined with low-dose aspirin is recommended to reduce the risk of major adverse cardiovascular event and major adverse limb events. Symptomatic peripheral arterial disease, single antiplatelet therapy, and patients who are undergoing revascularization procedure, either endovascular or surgical, combination of aspirin and low-dose rivaroxaban. These two are class 1 recommendation. Let's talk about concomitant medications. Can these patients benefit from anticoagulation? Can these patients benefit from lipid-lowering therapies? So the guideline states that patients with peripheral arterial disease who do not have a compelling indication, for example, atrial fibrillation, mechanical heart valves, rheumatic heart disease with mitral stenosis, should not receive full intensity oral anticoagulation to reduce the risk of major adverse cardiovascular or limb events. In the previous section, we discussed that these patients can benefit from low-dose rivaroxaban in combination with low-dose aspirin, but full intensity oral anticoagulants require a compelling indication. So this section clearly states that these medications in full doses should be avoided routinely. And in patients with peripheral arterial disease, treatment with high intensity statin therapy with an aim of achieving a more than 50% reduction in LDL cholesterol is recommended. This is a class 1 recommendation. And if the goal is not achieved with the high intensity or maximally tolerated statin therapy, and the patient still has an LDL cholesterol values of 70 milligram per deciliter or more, it is reasonable to add PCSK9 inhibitor therapy and or ezetimibe. And this is a class 2A recommendation. So to sum up, anticoagulation in full doses should be avoided in the absence of compelling indications, and patients should receive initially high intensity statin therapies, and if the goal LDL is not achieved with the high intensity statin therapies, these patients should in turn be started on additional lipid lowering therapies like PCSK9 inhibitors and or ezetimibe. In patients with peripheral arterial disease and hypertension, antihypertensive therapy should be administered to reduce the risk of major adverse cardiovascular event, and the aim should be a systolic blood pressure of less than 130 millimeter of mercury and a diastolic blood pressure of less than 80 millimeter of mercury. Every eligible patient should receive antihypertensive therapy, and the goal of antihypertensive therapy is to reduce blood pressure below 130 systolic and 80 millimeter of mercury diastolic. Selective use of angiotensin converting enzyme inhibitors or angiotensin receptor blocker is recommended to reduce major adverse cardiovascular events. These patients should receive guidelines directed therapy to reduce their blood pressure, and the best choice is to use either ACE inhibitors or ARBs for these patients to reduce major adverse cardiovascular events. Continuing with medications, in particular for patients with type 2 diabetes, the use of drugs which improve major adverse cardiovascular events, for example, glucagon-like peptides and SGLT2 inhibitors are recommended, and they are effective to reduce the risk of major adverse cardiovascular events. And in patients with claudication, cilostazol is recommended to improve leg symptoms and increase walking distance. However, cilostazol should not be administered in patients with congestive heart failure of any severity, and pentoxifylline and chelation therapy are not recommended for the treatment of claudication. Avoid these unnecessary drugs. Okay, the guidelines clearly have a very important section for exercise program, and the emphasis on exercise is evident from the recommendations. And the guideline states that in patients with chronic symptomatic peripheral arterial disease, supervised exercise therapy or a structured community-based exercise program with behavioral change techniques is recommended to improve walking performance, functional status, and quality of life. The benefits of structured walking exercise therapy that avoids moderate to severe ischemia is uncertain. However, alternative programs of non-walking structured exercise therapy, for example, arm ergometry, can be beneficial. And the usefulness of unstructured exercise to improve walking performance is uncertain. So, in all symptomatic patients, a supervised exercise therapy or structured community-based exercise program with behavioral change techniques is recommended, and it improved the walking performance, the function status, and quality of life of these patients. So this should be remembered. Another treatment option for these patients is obviously revascularization. In patients with asymptomatic peripheral arterial disease, it is reasonable to perform revascularization procedures to reconstruct diseased arteries if needed for the safety, feasibility, or effectiveness of other procedures. For example, if a patient has aortofemoral disease, obvious contraindication to or access site related issue with transfemoral TAVI. Although the patient is asymptomatic, the reconstruction of the diseased arterial segment is reasonable in order to safely perform the procedure intended, right? So in these patients, if they are asymptomatic, uh, it is reasonable to reconstruct their arteries either by surgical or endovascular revascularization techniques. The revascularization should not be performed solely to prevent progression of the disease, because this is a progressive disease, requires risk factor modification, intensive therapies. If you fix one segment of the artery, the disease may progress to another one. So in order to prevent the progression of the disease, other strategies should be implemented, and revascularization should not solely be performed in these patients. Okay? And in patients with functionally limiting claudication and an inadequate response to guideline-directed medical therapy, which includes structured exercise therapy, revascularization is a reasonable treatment option to improve walking function and quality of life. So the other indication is failure of the guidelines-directed medical therapy, including structural exercise therapy. Revascularization should not be performed when the patient has an adequate response to guideline-directed medical therapy, including structured exercise program. Okay, so if the patient is responding to medications, do not perform unnecessary revascularization. In patients with chronic limb-threatening ischemia, revascularization is recommended to minimize tissue loss, heal wounds, relieve pain, and preserve a functional limb. If patients with the chronic limb-threatening ischemia have non-healing wounds or gangrene, revascularization in a manner that achieves inline blood flow or maximizes perfusion to the wound bed can be beneficial. And ischemic rest pain in these patients from multi-level arterial disease. In these patients with the multi-level arterial disease, the principle and the goal of the revascularization should be to address the inflow disease first. An important section regarding follow-up: you have a recommendation on the diagnostic tests, you have recommendation on medication, on revascularization, on exercise. What are the recommendations on follow-up? In patients with peripheral arterial disease, with or without revascularization, longitudinal follow-up with physical examination is recommended. In patients who have undergone revascularization and have new lower extremity sign or symptoms, ankle brachial index and arterial duplex ultrasound is recommended. In patients who have undergone revascularization without new lower extremity signs or symptoms, the effectiveness of ankle brachial index and arterial duplex ultrasound surveillance is uncertain. So longitudinal follow-up, and if there is a change in symptoms or the patient's presentation, ABI and arterial duplex ultrasound should be performed. Thank you very much. This was in a nutshell the new recommendations from the ACC 2024 guidelines on peripheral arterial disease. In the next lecture, we are going to discuss key takeaways from the 2024 ACC Guidelines on Hypertrophic Cardiomyopathy. Thank you so much.